Okay. I'm going to be talking today about the longitudinal cognitive and social emotional trajectory of ADHD. And I'm going to be really focusing on the clinical implications of those. What do we do as clinicians when we have a young adult, a child, an adult with ADHD? What are the sorts of techniques that work best for them? What are the empirically standardized kinds of treatments? And I have a little bit to show you from my new book that Hannah just mentioned about motivation. And even though it's not written only for people with ADHD, of course, a lot of people with ADHD struggle with motivation. But let's start first just by reminding ourselves, what are the core symptoms of ADHD? And really, they fall into three categories, but I've lumped them into two categories here: the category of inattention and then impulsivity and hyperactivity. And when we look at diagnosing ADHD, we know, of course, that the diagnosis is made on clinical symptoms, even though neuropsychological testing can be very helpful in figuring out the symptoms of executive functioning that might be getting in someone's way. The diagnosis itself is still based on a clinical assessment of symptoms. We don't have any single test that's available that will tell us yes or no if a person has ADHD with 100% certainty. And in some ways, the symptoms are subjective, and they're definitely developmentally and contextually sensitive too. So, oops, sorry about that. So I'm assuming that we all know what ADHD is, and I'd like to just plunge right into what do we see? What does the research show in terms of the course of the disorder? So we have these two areas that tend to depart as a person moves into adulthood. So in ADHD, the inattentive symptoms tend to continue, and the hyperactivity and impulsivity symptoms tend to decrease as we move across. As you can see here, here's a person's age. The inattention symptoms continue, and hyperactivity and impulsivity tends to decrease. And what do those inattentive symptoms mean? Well, it's not just not paying attention, but it has major implications for people in the workforce. So problems with loss of productivity because they're not paying attention to what it is they should have been doing, tardiness because they're not paying attention to time, making mistakes because they're not paying attention, being disorganized, not knowing where things are when they're supposed to be, knowing where they are, and a disrupted workflow in general, whereby they aren't able to get sort of in a rhythm or in a flow to be really effective in a job. So those symptoms of inattention that sometimes in childhood we don't really think about as much because it's the hyperactivity and the impulsivity that get kids in trouble, they become much more impactful as a child moves on into adulthood. So when we look, though, at the symptoms and the predispositions, the factors that influence those symptoms, you can see at the top of this graph are the symptoms themselves. What do we see? And on the bottom part of this graph is what are the influences on those? So even in utero, there are genetic predispositions. And I'm going to talk just very briefly about genetics and ADHD, but we do know that there are genetic links to ADHD, and that fetal exposures and epigenetic changes in the fetus can lead to someone having more significant issues that could lead to ADHD. These are risk factors. So they're genetic risk factors, they're environmental risk factors, even in utero. When we look into childhood, what we see is there are a lot of different risk factors that might cause someone to express the full symptom picture of ADHD. So psychosocial influences, chaotic family environments, peer influences, a mismatch between school and work environments. So a child who has a teacher who is not consistent, not the right kind of teacher, might have a very bad year in school. Another child might do quite well if they're in the right kind of learning and academic environment. The same thing that I find with adults with ADHD, sometimes they do quite successfully until they get a promotion at work where they have to now do a whole new skill set, and that becomes very difficult for them, and the symptoms of ADHD become more prominent. So different genetic risk factors affect the course of ADHD at different stages of the lifespan. And then it also mentions here what's happening in the brain. What are the sorts of things happening in the brain that might cause someone to continue to have symptoms of ADHD as they move on in the lifespan? And what are those symptoms? Oh, can I just say for 1 second, I do hear somebody on there unmuted, and I'm afraid it's interfering. If somebody has, I don't hear it anymore. But anyway, I was hearing someone in the background, and just want to make sure you weren't too. So when we're looking at the symptoms themselves of ADHD, what we see in very early childhood is a lot of behavioral disinhibition. The issue of impulsivity, touching everything, can't sit still, hyperactivity. Oftentimes speech, language, and motor coordination problems are early symptoms, or like prodromal symptoms of the full expression of ADHD. I find myself that one of the things that is an early marker is poor fine motor skills. In a fair number of kids that we've seen in our studies, a fair number of kids with problems with fine motor skills tend to have the full expression of ADHD as they move on. And then we also see, as people with ADHD move into adolescence, a lot of comorbidity, school failure, peer rejection. Around time of adolescence, things like smoking initiation. Number of reasons for that. One is inability to inhibit one's impulses when presented with something like that, but also some people will say it helps them sort of focus, attend. Whether or not that's true is a totally different discussion, but it can lead to other things with substances as well. So as the ADHD person moves into adulthood, they're at higher risk for substance use, low self-esteem, and social disabilities. And the more recent research on ADHD does sort of look at social disabilities as part of the picture of ADHD, even though it's not one of the DSM symptoms. I just wanted to mention too that genomic analyses show overlap between ADHD and other conditions. So anytime we think about, all right, what does ADHD look like through the lifespan, we have to think about the fact that it's not often just ADHD. And what are those kinds of symptoms and psychiatric disorders that we see? So you can see here, the psychiatric disorders show many significant correlations, and with things like anorexia, anxiety, but significantly bipolar disorder, MDD, schizophrenia, Tourette's, PTSD, and so on. So we've got to kind of think about these sorts of things. You can see here, when you're looking at the graph, the significant values for those. But there's quite a bit of significance between ADHD and nearly any other disorder that you can think of. Less so here for ASD, which may be because in years past you couldn't get a diagnosis of both ADHD and ASD, so that's a little bit murkier. But we've got to be able to think about the child with ADHD and anxiety disorder or major depressive disorder. One of my areas of research is in the area of processing speed and how it relates to ADHD. And processing speed is the speed at which we're able to take in information and give a response for it. And we found in my own research, processing speed is often impaired in children with ADHD. About 70% of kids with ADHD will have impaired processing speed. It's greater in older children referred for clinical evaluation, which sort of raises the possibility that that processing speed weakness may increase with age. We also know, though, that ADHD is often comorbid with reading disabilities, and research has supported the idea that processing speed is the shared cognitive deficit between reading disabilities and ADHD. So people with ADHD and reading disabilities together may be at even more risk for school failure and job insecurity. This is from one of our studies. It's not a longitudinal data set. We are actually looking at that right now. I'm old enough now to look at data longitudinally in a meaningful way. But what you can see here is at age 6 and 9, here's the processing speed index. I've got boys and girls. One thing to notice is that in people with ADHD, it's an ADHD sample, boys have slower processing speed than girls do. At ages 6 and 9, though, they're about the same. It's not significantly different. As they move on into early adulthood, we see that this minor difference becomes significant. So what this means is that boys with ADHD become more impaired in processing speed, at least in a cross-sectional sample, meaning that this is another area of treatment and another area to think about as we are looking at the trajectory both of males and females. So that difference becomes even more significant in that 13 to 21 year age group. So more to come on this, but something to think about, that there are gender differences, especially in processing speed, particularly for individuals with ADHD. So, and I'll get back to some of these. What do we do about that in a few minutes? So one of the other questions that has come up in the last 8 to 10 years is ADHD always a neurodevelopmental disorder? There's still a lot of arguments about this, but recent population studies have raised the question as to whether ADHD is always preceded by a childhood onset of symptoms, which is why it gets the name neurodevelopmental disorder, or if it can develop anew in adult life. And the research is a little bit cloudy on this. I think we're still learning a lot about this. One article by a couple of colleagues of mine, this is a few years ago, said yes, that adult ADHD can happen can occur, and that they cited a number of studies that were done. There are a few reasons for this. One might be that people just never aren't very good reporters of their own childhood symptoms. So there were symptoms there, but that it's also the fact that the functional impairment, the symptoms could have been there in childhood, but did not lead to a functional impairment. And so in adulthood, there's something about that happens in adulthood that occurs where an adult might have functional impairment, same sorts of symptoms that they had as a child, but it didn't lead to impairment. So it's an interesting thing to think about. I think this is another area that we're seeing a lot of research in, for instance, women going through menopause who may have this onset of what seems like ADHD, who might have a history of underperforming in school, but no one ever diagnosed them with ADHD. So it could be considered an adult onset disorder. So the other issue that comes into play here with adult onset ADHD is that the symptoms and impairment merge due to accumulation of environmental risk factors, meaning that you can sort of take a hit in elementary school. Okay, you're underperforming in elementary school, but you're kind of holding it together. And as you move on to university, it becomes more difficult for you. And so those losses, those small losses where you can sort of function without a diagnosis, become much more burdensome. And that, along with the symptoms that were originally there, along with the environmental genetic risk factors, become something that is much more of a diagnosable disorder. And such, the researchers who are behind this push for adult onset ADHD say there's no clean separation of etiological risk factors above and below the age of 12. So as most of us know, before DSM-5, there was a cutoff of age 7 for ADHD. They raised it to age 12. My guess is that as time goes on and we get the new iteration of DSM, this will probably be at least addressed in some way. So adult life, what does this look like? Well, ADHD symptoms levels in general, I mentioned that if anything in continues, it's the inattention, but the symptom levels in general decline with age. But about 50% of those who are diagnosed as a child will continue to have symptoms later in adult life. And the genetic studies have observed that ADHD persistence is associated with higher genetic loading. So I'm not going to go into all of these studies, but it really is, it has been shown in a number of different studies that a significantly higher relative risk factor genetically in, well, let me say this, a higher relative risk of clinically recognized ADHD in siblings of those who had ADHD at age 18 showed a higher risk factor. And so what is important is that ADHD tends to be more significant in families that have a significant presence of ADHD. And that ADHD is more persistent over time. Now, in terms of treatment, the most effective treatment is multimodal. I think we're all psychologists here. I am only showing you one small slide on the medical treatment because it's not what we concentrate on, but I think it's important to sort of, because a lot of times we as psychologists are asked to weigh in on whether or not medication is the right or the wrong way to go. And so one of the things we can do with patients is to weigh the barriers and the benefits. So the risks and the benefits. So I have here on this, in this chart, the barriers are things like the psychological side effects, the fear of side effects, the actual physical side effects, worry about it's not going to be effective, and sometimes it's not, difficulties getting refills of prescriptions, financial concerns sometimes, especially in the US, where sometimes it's covered by insurance and sometimes it's not. And the medications can just be difficult to get. So those are all barriers that are going to affect how likely someone is going to adhere to a medication regime. And so the more we can do as psychologists to help them with these, to talk through about some of these barriers, the more likely they're going to adhere to the medication. And so what are some of the benefits? Well, we can talk about that with them. Increased focus, decreased impulsivity, and that relates to a better quality of life. And so what, you know, in terms of the benefits, you can see here too, without treating some of these issues, where the patient will have impaired relationships, financial problems, school failure, job loss. So you've got to be able to talk with them about that as well, and how that relates to ADHD. And one of the things in terms of this perceived severity, it helps us when we perceive that there is a significant risk factor in one of these areas here, that it calls us to action. And a positive or a negative relationship with a healthcare professional can also impact that quality of life. So all of these things are related, and we do play, even though we don't prescribe medication, we do play an important role in helping people adhere to medication and help them to understand the importance of it when it is something that is considered to be useful. So let's talk a little bit about ADHD as an executive functioning disorder. And some of this comes from Russell Barkley's research, where he really feels like ADHD is an executive function disorder. So the answer to the question, does ADHD equal an executive function deficit disorder? The answer sort of is yes, because of the neuroanatomy and the neuropsychology of ADHD. And I want to go into just a little bit of information about this and just talk a bit about the prefrontal cortical networks involved in executive functioning are also the networks implicated in self-regulation and in ADHD. So just as a sort of a recap, the frontal striatal circuit is associated with deficits in response suppression, freedom from distraction, working memory, organization, and planning. known as the cool or the what executive functioning network. So again, these are networks implicated in self-regulation and in ADHD. The frontal cerebellar circuit associated with motor coordination deficits, problems with timing, timeliness of behavior, known as the when executive function network. I mentioned before that I often see in early childhood and even in elementary school, 6, 7, 8, 9, 10-year-olds, just poor handwriting. That is part of this. The reason why I think sometimes for a fair number of people, it's part of ADHD. It's because of this circuitry not functioning as well as it could. And then we have the frontal limbic circle associated with emotional discontrol, motivation deficits, impulsivity, hyperactivity, that proneness towards aggression, and the hot or the why executive functioning. So the cool executive functioning is the executive functioning that you see when everything's fine. They know what the right answer is. And on many of our neuropsychological tests, they do quite well because the environment is cool. It's just me. I'm just asking them questions, asking them to do something, or they're sitting at a computer responding, but everything else is cool. It's not complicated. It's not emotionally, they're not emotionally vulnerable. Where hot executive functioning, it's the kind of executive functioning skills that you need when the stakes are high, when there's lots going on around you, when you're an adolescent in a classroom and there's all sorts of tensions and things going on, temptations. And that's where really a lot of adolescents get into trouble. Oh, and here are just some of the, sorry about that. Okay, there we go. And just as a reminder, so here are those brain networks. You can see here too, it's the issues in the area, the prefrontal cortex, reality testing, error monitoring, top-down guidance of attention and thought, emotion regulation, and all of these have to also do with direct norepinephrine and dopamine regulation. And so it's complicated, but what we're really talking about is the part of the brain that is affected in ADHD are indeed the areas of executive function skills. So when we look at whether or not ADHD can fit into the executive function domain, what we really see is that there are two broad dimensions here. One is inhibition, which involves motor, verbal, cognitive, emotional. And then the other is more attentional, which involves metacognition, nonverbal working memory, planning, emotional self-regulation, and all the different working memory skills. All right. So you can kind of think about that. So if we build a theory of executive functioning and ADHD, we want to link those, that inhibition, self-control, and executive functioning. And one of the ways that we can do this is by looking at what do people need? What are the skills someone needs to drive? And this is Mishan's model of driving. And Russell Barkley has used this model to make a model of executive functioning for people with ADHD. But let's just kind of think about this. So level 1, what are the basic cognitive abilities required to drive? You need normal reaction time. You've got to be able to see, of course, visual perception. You need motor speed, agility. You've got to be coordinated. You've got to be able to hear or at least be accommodated for that. Language and reading abilities are also necessary. Or again, you need to become accommodated for that. But then you also have to have an ability to operate the machine itself. So you've got to be familiar with the sound and management of the vehicle. You've got to know where the window, how to do the windshield wipers, how to brake the car, how to accelerate, where the mirrors, seatbelts, all of those sorts of things. And then you need sort of the tactical abilities, the ability to operate the vehicle on the roadway. So the operational abilities are like, I can drive a car in a parking lot, but the tactical abilities are, I have the ability to operate the vehicle on roadways where other people are also driving cars, and I know the driving laws. I know how to drive safely. Oops, sorry. And then on top of it all is the strategic abilities, the purpose, or knowing why you're driving the car, how to get to the place you're getting to attain your goals, the time needed that it takes to get from your house to wherever you're going, the knowledge you need to effectively do a plan. So, it's going to rain, you might have traffic, there are accidents in construction. So I think this is a good way of sort of thinking about ADHD and executive functioning, that all of those components are important. And Russell Barkley has used this example as a way of talking about executive functioning. So here's his definition of use of this. Executive functioning is the use of self-directed actions, self-regulation, to choose goals and to select, enact, and sustain attentions across time toward those goals, usually in the context of others, and often relying on social and cultural means. This is done for the maximization of one's longer-term welfare as the person defines that to be. So what does this look like when he puts that same model and combines it with ADHD? So what he says is the instrumental things that someone needs in order to be successful in life are self-directed abilities. So they're things like self-awareness, executive inhibition and interference control. We have to have sufficient verbal and nonverbal working memory. We've got to be able to plan, to problem solve, regulate our emotions. So those are the instrumental things. But then there's also the methodical things, the self-reliant abilities that we need. So we have these self-directed abilities are there, but now we've got to sort of apply them. And those sorts of skills are essential for daily adaptive functioning, our self-care, our social sort of self-defense and ability to get along with each other. So there are things like self-organization and problem solving, self-management to time, self-resistance, self-motivation. And on top of that, there are those tactical, again, sort of thinking about taking the car out on the road with other drivers. And that underlies human social exchange. So turn taking, reciprocity, keeping your promises, the basis of economic behavior. I do this, you do that. It's even things like ethics, social skills, etiquette. Oops. And then at the top, we've got those cooperative abilities. So now we're, again, if we take this kind of thinking about the car driving along the road, a person with a license, this is like, where am I going and how am I getting there most efficiently? So it's a group situation. It is thinking about, okay, what do I want to do for my next job, for example? It underlies any kind of cognitive venture, division of labor, formation of communities, formation of classroom situations. So all of these things are important. So what you see here again is we're talking about these areas of the brain, these sorts of, and I don't know what sort of happened here with my slide, but you can see that all of these things are quite important. That, neurological maturation and increased valuing of delayed outcomes and reliance on cultural methods and products. So you can see that these are the sorts of things that we kind of think about as we are trying to understand ADHD, and especially according to Barkley's model. So what does that mean? So ADHD disrupts the 5 levels of executive functioning, but especially the tactical and those higher levels. So thereby, what it creates is a disorder of self-regulation across time. And many of us believe that ADHD can be considered as time blindness or a temporal neglect syndrome, like myopia to the future. Like they just can't even imagine the future. And we do know that time is impaired in people with ADHD, their ability to sense time, their ability to get a sense of time. And so it adversely affects the capacity to hierarchically organize behavior across time, to anticipate the future, to pursue long-term goals and self-interests, and to know what's going to make you happy. So many people now believe it's not an attention deficit, but an intention deficit. So meaning in attention to mental events and the future. So they don't have intention, meaning it's hard for them to know exactly, okay, this is my intention to do this. So when we think about this, it's a disorder of performance, not skill. Doing what you know, not knowing what you do. The when and the where, not the how or the what. And using your past at the point of performance. So it's, let me see if I can explain this a little bit better. So when we think about the implications of those things, teaching just plain old skills isn't adequate enough. We can't just teach someone with ADHD to learn how to organize themselves especially not in the theoretical way. The key is to design environments around the individual to compensate for their executive function deficits. And therefore, the effective treatment are always at where it happens, the point of performance, not just in our offices, but really where they're happening. And for the adult, that might mean in the office setting. We have to remember that these deficits are neurogenetic in origin. Medication, of course, may be essential for most, but there is quite a bit of evidence now that suggests some executive functions might also be partly responsive to direct training. And I mentioned here too, this doesn't mean that people with ADHD are not accountable, but we've got to help them learn about these issues of time and timeliness. In terms of children, the current research still shows that cognitive behavioral therapy doesn't work really well with children with ADHD. It may just be that there are not the right kinds of treatments yet, but there are being developed, and we still do it and use it, even if the data is not extremely strong. I think part of the reason why CBT for kids doesn't always work is it's not happening at the point of contact, meaning it's got to be happening in the classroom or in the home settings and not only in the office. For adults, it is more effective. Adults are able to generalize more. And what we really need to do is that the best point of intervention, as I was saying before, is at that point of performance. That is when the person is in the action of some kind, intervening at that moment. If you wait till later, it doesn't always work very well. And that's why for kids, what we find is that skill set that's done in an office isn't always that successful of changing the behavior. Therapy can be very helpful for kids in dealing with all the social emotional issues that come with ADHD. That can be very, very helpful. So if we look developmentally on the CBT interventions for ADHD, what we find, the data shows that for preschool age parent training, multimodal interventions in the school primarily are most helpful. School age still parent training is very helpful, helping parents understand what is ADHD, what can I expect, and teaching them how to intervene in the moment. And then also classroom-based interventions, intensive summer programs, and multimodal interventions, again, looking at some school, some home, at this stage, maybe even medications. Adolescent CBT, especially for comorbid disorders, organizational and skills training, and then for adults, similarly, CBT and organization and skills training is when those are most helpful. So you can see here, this is just, here you've got the core neuropsychiatric impairments in attention, inhibition, self-regulation, can lead to a history of failure, underachievement, relationship problems. And then what happens is people have dysfunctional cognitive beliefs about themselves, which leads to mood disturbances, which can lead to failure to utilize those compensatory strategies that we have, like organization and planning, which can lead to that functional impairment. Now, remember, I was talking to you about adult onset ADHD, and that maybe there's a core group of people who always had these impairments here. and who, as over time, a little bit of problem lead to them feeling like, well, I'm not that good. I'm not a good student. I'm disorganized. I'm forgetful. That can lead to them feeling sort of some of this depression, anger, and the things that they were able to make use of earlier in their development don't work anymore. And that leads to that functional impairment. So this might be a model for what happens for adults who have mild symptoms in childhood, but who don't seem to have functional impairment until adulthood. So one of the things to come out of my newest book and research is, how do we help these parents and kids and adults who have ADHD by looking at their motivation? Now, I'm not going to go into a big lecture on what motivation is, because we all know what it is. But one of the things that I found is that people with ADHD tend to have a lot of difficulty with motivation, getting started on tasks, even knowing what it is they want to do. And so I developed this strategy called the APP. So the APP stands for aptitude, practice, and pleasure. And so what we really want to think about when we're thinking about helping someone develop a sense of motivation is to think about this intersection here. We want them to be in a space where they are using their aptitudes that they naturally have. They're doing things that they naturally practice and doing things that give them a lot of pleasure. So for kids with ADHD, they're oftentimes put into situations where they, low aptitude, they're in school, they don't have an aptitude for the kinds of things that school requires. I'm not necessarily saying intelligence here. I'm saying an aptitude for organizational skills, for paying attention, for sitting in their chair. And they also don't spend a lot of time doing those things that would help them get those skills. And of course, they're not getting a lot of pleasure out of that. So lots of kids have a low motivation because they're in this area of a personal weakness. So let's just talk about each one of these, because each one of these can be strategies for helping people with ADHD figure out how to get more motivated. And I do this with kids and with adults and with parents. So aptitude is kind of what you think it is. It's those areas of specialization, those behaviors that are very easy for us to master, and that it can sometimes be just an awareness of ourselves. So it doesn't have to be intelligence. We always think aptitude and intelligence are the same thing, but intelligence is just one kind of aptitude. You can have an aptitude for humor. You can have an aptitude for empathy. There are lots of other things that perspectives we need to think about. And a lot of times parents will say, well, I don't think he has an aptitude for anything. He's just terrible at it. And so one of the things I tell people to do is look at your child's previous testing through school, ask a child's teacher, look beyond those typical aptitudes and think about character. Think about the sorts of things that what outsiders say about a child. And then pleasure, which is the second part of this, are the things that give us pleasure. And a lot of times I find that kids these days really don't spend a lot of time doing pleasurable things. Video games, social media, for the most part, are not pleasurable activities. They're activities that people do when they don't really know what else to do, to be honest. I find myself scrolling through Instagram when I have things that I need to do or when I can't figure out what I want to do, not because I'm like, oh, I can't wait to get on Instagram, unless it's maybe to see a picture of one of my kids. So, but anyway, how do we get at pleasure? Because a lot of kids that have ADHD do not have a lot of pleasure in their lives. So what to notice? When are they smiling and laughing the most? What are they curious about? What have they enjoyed in the past? What do they seem to light up about? And I think what we need to do for kids is to help activate that sense of pleasure, playing without a product that is at the end, scheduling time to play, time for boredom. I get asked a lot, what's the number one thing you'd recommend for people with ADHD? And it would be like good sleep hygiene. That is probably the number one thing that all of us are suffering from. I even mentioned things like keeping a happiness calendar. So this can be a way of helping kids become more motivated because we're more motivated to do things that make us happy. But a lot of times kids with ADHD aren't even aware of what makes them happy. So getting them more focused into that by infusing this either in the classroom, at the dinner table, as adults, it's important to sort of talk about valuing fun and pleasure. And then practice is the sort of things like, what do we persist at doing? And so it's a sort of thing like, given unlimited time, would I pick up a book? Would I pick up a guitar? Would I go for a walk? Would I go for a run? What are those sorts of things that, and they may not be an aptitude. It may, like the things that we practice, sometimes we're practicing because we want them to be a better aptitude. So we need to sort of think that not all of these things fall one on top of the other. So where we want to be is in this area of flow. So practice, again, is where aptitude and pleasure combine as a desire to do something. And that practice requires concentration, the sort of thing that, again, video games aren't really part of that, but it's the sort of thing where practicing a guitar, playing the piano, playing chess, for example, those sorts of things. But in our world today, there are a lot of distractions that get in our way of the ability to practice. So I've listed some of these here. And for kids with ADHD and adults with ADHD, a lack of success in the past is one of those. So how do we support people with ADHD making aligned choices? Well, we want to think about what are the sorts of things that light them up. This can be done at a very early age, but I do this even with my ADHD clients, even at older age. What are the sorts of things you're good at doing? These are conversations that people with ADHD don't tend to have. What makes you the happiest? What makes you the most frustrated? Who do you admire? Filling in that graph with them can be a very useful way of helping them figure out what their goals are. I'm going to just go over this very quickly, but what I do in my practice and what my new research and book is on is about using that app to set some good goals. And I have here goals are, here are most of you are familiar with goals. They're chosen, they're clear, positive, mastery focused. But I think the most important thing is to think about their specific, there's something we can measure, there's something we can attain, they're relevant, and they're time-based. So when goals are like this, about 90% of the studies conducted about goal setting found that specific and challenging goals had an effect on performance. But they've got to be aligned with who we are. So I find that kids with ADHD tend to have goals that are way too lofty. Oh, this year I'm going to get all A's. I'm going to, let's start with just a smaller goal that's attainable. And so some of the things I ask when I'm talking to students with ADHD, what makes you happy? What do you look forward to? These are ways of kind of generally generating positive goals. But it's not just a one-time thing. Goal setting sets up a powerful cycle, which builds that intrinsic motivation and the real life skills. So when we're thinking about those skills that need to be at a point of practice, goal setting allows us to figure out in the real world, what are the skills that you need? And then that doesn't stop. Once you make a goal, that's just a starting point. It's got to be something that's revisited. It's got to be something that, especially people with ADHD, are constantly getting feedback, thinking about what worked, what didn't work, letting a child struggle for a while, but not too long, teaching how to ask for help, knowing even in the goal setting process what it is that needed to be involved in accomplishing the goal. So once you've identified a goal, what is it that needs to be accomplished? Why is it important? Who needs to be involved? And what are the resources that you need? So I've given an example here of something that I work with. I'm just going to talk, I think we go till quarter after. Is that right?
It's okay. You can talk, I think, till 5 o'clock, and then we will have time for discussion.
Oh, perfect. Okay. So I did want to talk a little bit more about some of the generic issues associated with adolescence, because this is really the most difficult time, I think, the most risky time for people with ADHD. So what happens in adolescence is that, of course, there's a lot of neurological maturation. There's also maturation of sexuality, which just gives more opportunities for problems, also pleasure, of course, but really it can make it very difficult for someone who can't inhibit their impulses. There's this desire to individuate from your parents, but that leads to the parents having less of an influence on their teen's behaviors. And especially since the teen is spending less time from the parents. Some of the research has shown that increasing number of domains of major life activities can be affected in people with ADHD, especially driving, more driving accidents, problems with money. They're more apt to be involved in crime, illegal drug use, inappropriate drug use, greater, and part of it is that they've got a greater involvement with and influence of other peers. And most of these are adversely affected by that delay in self-regulation. I've mentioned this before, the hyperactivity declines more steeply than does inattention. But what happens to the adolescent, and definitely in older adults, is that hyperactivity turns into a motor restlessness, which becomes sort of a subjective or internalized sense of feeling a need to be busy all of the time. And for some, a transition to middle school is associated with a transient increase, a reversal of the decline in ADHD symptoms, meaning that you might have a 7-year-old who's quite hyperactive. They tend to get better. And then as they reach that early adolescence, they become a little bit more hyperactive again. So even though over the lifespan, those hyperactive symptoms are going down, there can be a bump in those symptoms of hyperactive or impulsive behavior. And so that impulsivity, again, is more related to non-academic domains. And I've mentioned them here: the development of oppositional defiant disorder, drug experimentation, speeding while driving, risky sexual behavior. That involves even things like social media, sending inappropriate pictures to peers, those sorts of things, impulsive verbal behavior, and reactive aggression. But it also has some adverse effect on non-academic functioning too. I've mentioned this, some of these things before. This is just a list of some of the studies that have been done, and I've got a resource list if you would like them. I just didn't have room to put them all on the slides. So traffic accidents, various sorts of things, accelerated use of nicotine after experimentation. So lots of kids try smoking cigarettes, tobacco, but people with ADHD tend to be much more likely to use it again. There's that question again of self-medication, and they're inattentive to others' comments and needs in social activities. Poor work performance, part-time employment settings are common. So what are the sorts of tips then for teens? Well, ADHD medications, of course. There's the use of a coach or a mentor. Sometimes we as psychologists function in that. Sometimes, though, it's a teacher or someone in the school setting. I really find that since the research is pretty clear on that point of contact being important for the person with ADHD, having somebody in a school setting, of course, this doesn't happen, not even in the US and in most schools, but ideally to have a coach or a mentor in a school setting, which could meet with the child 3 times a day for 5-minute checkups across the day to sort of master some of these tasks, would be ideal. And so that would really take identifying somebody at the school who could then act as a liaison between issues between parent and school. So what are we talking about when we think about executive functioning over the lifespan? Well, here are the issues that become more impactful. Poor working memory goes into not being able to follow through on promises and commitments to others, increasing adverse impact of reading, listening, viewing, comprehension. all of those things in school settings and in work settings. That impaired planning that we see leads to reduced valuing of future rewards relative to peers. Remember, they have trouble with that intention. So it's like, oh, I don't know, I don't like my job. Well, what kind of job would you like? Or I don't know. They have difficulty with that. And so they don't persist toward future goals and show a very poor delay of gratification, deficient sense of time and time management. You can imagine that that's really a restricted temporal window relative to peers. And then poor emotion regulation leads to problems with anger control in some people with ADHD and frustration tolerance. And of course, that's going to lead to problems with social relationships and partnerships. And then that decreased fluency that we're seeing, which may even become worse as time goes on relative to peers, can make everything much slower and more difficult. One last thing, and then I'll open it up for questions. One of the things that I do find in people with ADHD is they tend to be overly positive. And part of that is that time perception. They don't understand the concept of time. And so they'll have a task to do. It will take a normal non-ADHD person 45 minutes to do it. They'll think they could get it done in 20 minutes. Part of that is that they don't understand what 20 minutes feels like versus 45. And then what happens is that everybody's disappointed that the task didn't get done. So one of the things to hear as you're working with people with ADHD at all levels, young childhood into adulthood, is red flag kinds of thoughts. And teaching them to be responsive to those too. I don't need to worry about this. It'll all work out. Don't worry, just chill. Or I can get one more thing done before I leave, or I have to do this interesting thing right now, or don't worry, it'll all get done, when you know that it probably won't get done. And what happens is that these are the sorts of things that lead to, I don't need to worry about this, means that sometimes they just avoid it completely. It will all work out because I'm a good person. Well, leads to failure to consider realistic consequences. I can get one more thing done before I leave. Well, then they impulsively respond. Or I have to do this interesting thing right now. Well, that leads to negative reinforcement of overly positive thinking, and not necessarily the best way to manage your ADHD. So that's a really wonderful thing in some ways. Adults with ADHD can oftentimes be very positive, can do attitude, but lack the skills to actually do it. So as part of a team, they can be a wonderful team player in adulthood, but they also then need to balance the team with other people who are organized and also need to know what they need to do in order to get the tasks done. So in conclusion, the CBT can be useful for some of those things. There's good efficacy for adult ADHD. Preliminary results are promising for adolescents with ADHD. And then I have here too, more work is needed in those adolescent populations. And so in conclusion, as you know, ADHD disrupts the behavioral inhibition, and by disrupting executive function, it affects those, inhibits behavior, our thoughts, words, emotions, our ability to manage time, anticipate and prepare for the future, that intention, self-organize, self-motivate, and self-activate. And you can see here too, I have across time. So it's not just self-motivating now, but self-motivating now and consistently. So I mentioned that there are a couple of books. One of my books came out about bright kids who can't keep up. It was about 8 years ago. And I've done a lot of research since then, but there's a lot of research in there about processing speed. And then this is my new book, Bright Kids Who Couldn't Care Less, which has more of my research about motivation, which I mentioned some of it. I know I went by very fast, and I'm sorry it was so quick, but I'd love to hear what you have to say and what questions you have.